Hello, this is Jonathan Kay reporting virtually from Massachusetts on day one of EULAR 2022, which is being held in Copenhagen. This is a very successful meeting, again, with over 9,000 participants attending and enjoying unusually sunny weather in Copenhagen. At the EULAR recommendations session, Joseph Smolin presented the 2022 update of the EULAR recommendations on the management of rheumatoid arthritis. And in the rheumatoid arthritis abstract session, there were a number of interesting presentations, including one about increased mortality risk in patients with incident rheumatoid arthritis and depression in a large cohort with 10 years of follow-up, and another about the discordance between DAS28 ESR and powered Doppler ultrasound during treatment of patients with early rheumatoid arthritis. Joseph Smolin reviewed the brand new 2022 update of the EULAR recommendations on the management of rheumatoid arthritis. These recommendations include two major changes from the 2019 EULAR recommendations, one being a recommendation to consider short-term glucocorticoids when initiating or changing conventional synthetic DMARDs, and the other being a change in the patient population for which JAK inhibitors should be considered. The most recent American College of Rheumatology treatment guidelines for rheumatoid arthritis indicated that conventional synthetic DMARDs should be initiated without either short-term or longer-term glucocorticoids because of the potential toxicity of glucocorticoids. The data supporting the recommendation to not initiate glucocorticoids for the short term, less than 3 months, was very low, and this was a conditional recommendation. And the data regarding longer-term glucocorticoid therapy was supported by only moderate data and was a strong recommendation. The EULAR guidelines development group, which was multinational, including representatives from both North and South America, Asia, Australia, and Africa, in addition to European members, recommended that short-term glucocorticoids be used when initiating or changing conventional synthetic DMARDs, but they be tapered and discontinued as rapidly as possible because of the increased cardiovascular risk with longer-term glucocorticoid therapy. They based this recommendation on data from the North Star study, which showed that treatment with methotrexate and glucocorticoids was non-inferior to treatment with methotrexate and each of 3 different biologic agents. The other recommendation was based upon the oral surveillance study, which identified an increased incidence of major adverse cardiovascular events and malignancies with JAK inhibitor therapy, tofacitinib, compared to TNF inhibitor therapy, adalimumab or etanercept. Although this increase was not significant, the JAK inhibitor was not non-inferior to TNF inhibitor therapy in terms of incidence of major adverse cardiovascular events or malignancies. This prompted the United States Food and Drug Administration to change the label for JAK inhibitors so that JAK inhibitors can now be prescribed only for patients who have already been treated and failed treatment with a TNF inhibitor. The EULAR group changed the recommendation by indicating that JAK inhibitors should be considered for use in patients with poor prognostic factors without risk factors for major adverse cardiovascular events or malignancies. They still positioned JAK inhibitors along with biologic DMARDs for use after the failure of the first conventional synthetic DMARD in patients with poor prognostic factors, but added this caveat. They also combined 2 recommendations regarding tapering of medications to one recommendation, which reads that after glucocorticoids have been discontinued and the patient is in sustained remission, dose reduction of DMARDs may be considered. And this includes not only conventional synthetic DMARDs, but also biologic or targeted synthetic DMARDs. There was a very interesting oral presentation by Jens Petersen from the Department of Medicine at Odense University Hospital in Denmark, oral presentation OP0067, which found an increased mortality risk in patients with incident rheumatoid arthritis and depression in the DanBio registry. These investigators looked at over 11,000 patients with incident rheumatoid arthritis, not previously on antidepressants, who were enrolled in the DanBio registry, and they combined the DanBio registry with the Danish National Prescription Register and several other registries to use the first filling of antidepressants as a surrogate for the diagnosis of depression. They found in patients with rheumatoid arthritis younger than 55 years, there was an adjusted mortality risk of 6.66 with antidepressant exposure compared to no antidepressant exposure. In older patients with rheumatoid arthritis, this mortality risk was increased about threefold and was slightly higher among those with seropositivity compared to those who were seronegative. They concluded that the diagnosis of depression, defined as first filling of antidepressants, was associated with a greater mortality risk in patients with incident rheumatoid arthritis. However, using filling of antidepressants is problematic since antidepressants are prescribed to patients to treat chronic pain. Patients with active rheumatoid arthritis experience pain and might be prescribed an antidepressant for pain management. And patients with active rheumatoid arthritis have increased cardiovascular and malignancy associated mortality risk. However, these investigators performed several other analyses, one of which used the ICD-11 code for depression instead of antidepressant prescription as a measure of depression, and found similar findings of increased mortality risk in patients with rheumatoid arthritis and depression. The other abstract that I will discuss, OP0082, was presented by Rudresh Shukla from the University of Manchester in the United Kingdom, who looked at the discordance between DAS28-ESR and the presence of ultrasound-powered Doppler synovitis during treatment for early rheumatoid arthritis. Now, it's known that about 25% of patients with active rheumatoid arthritis by CDAI have discordance between the ESR and CRP. And it's also known that about a quarter to a third of patients who are considered to be in clinical remission have powered Doppler ultrasound signal detectable. Conversely, in some patients with active rheumatoid arthritis, powered Doppler signal is absent. So these investigators sought to look to see whether there is a concordance or discordance between the presence or absence of powered Doppler signal in patients with active rheumatoid arthritis defined by DAS28 ESR, and to identify clinical factors associated with the development of discordance following treatment in 120 patients, all of whom had active disease. They found that in these patients with active rheumatoid arthritis, 2/3 of them had concordance between DAS28 ESR and powered Doppler ultrasound evidence of disease activity, and 1/3 were discordant between the two. The DAS28 ESR and individual components of the DAS28 ESR were higher in the patients who had concordance between DAS28 ESR and powered Doppler ultrasound compared to those who were discordant with respect to those two measures of disease activity. The presence of higher CRP at baseline was more likely to be associated with concordance than with discordance in patients with active disease, and also was more likely to be associated with active disease and concordance than with remission and concordance. Treatment at baseline with etanercept and methotrexate favored the development of remission with concordance between the ESR, the DAS28 ESR and powered Doppler ultrasound compared to active disease and concordance at both weeks 12 and 24. So in conclusion, this group identified patients with both concordance and discordance between the disease activity measure, the DAS28 ESR, and powered Doppler ultrasound as an imaging measure of disease activity. They found that patients who had active disease in concordance between these measures at baseline progressed to discordance early on with treatment in about a third of patients, and also found that early treatment with etanercept and methotrexate increased the probability of clinical and imaging remission as early as week 12 and continuing on to week 24. Understanding the underlying biologic basis for these phenotypes will be important to design optimal treatment and management strategies. So I've talked about three presentations, the presentation of the 2022 update of the EULAR management guidelines for rheumatoid arthritis, an interesting study in the DanBio register, which identified an increased mortality risk in patients with rheumatoid arthritis and depression, and then another study which showed a discordance between the DAS28 ESR and powered Doppler ultrasound, indicating that one needs to measure perhaps both of these to get a better picture of disease activity. There were other interesting presentations about which I don't have time to discuss now, but for more information about these and other studies presented at EULAR 2022, go to rheumnow.com. I'm Jonathan Kay, and I look forward to seeing you tomorrow.